Welcome to the CTA podcast. Join us as we critically examine the ideological capture of the psychotherapy field. Here we discuss better, common humanity proposals for a fairer society. Our discussions are thought-provoking, and our guests are from diverse backgrounds, bringing unique perspectives to the table. This is the CTA podcast with your hosts, Jaco van Zyl and Christine Siefen. We are still promoting the recently published book, Cynical Therapies, Perspectives on the Antitherapeutic Nature of Critical Social Justice. And we're very excited to have Stella O'Malley and Sasha Ayad as our guests today. So Stella O'Malley is a psychotherapist, an author, and a public speaker in Ireland. She's also the founder and director of Genspect and the co-host of Gender A Wider Lens podcast, along with Sasha Ayad. So Sasha Ayad is a licensed professional counselor from Arizona, whose work is focused on adolescent onset gender identity issues. She discovered that teens were developing gender dysphoria only after adopting a trans identity, which is quite interesting. And I hope we can elaborate a bit on that in our discussion today. And she's also the co-host of Gender A Wider Lens podcast. So how about we start with the two chapters? Chapter 6, Transitioning Children, the clinician's assumption and client suggestibility.
Yes, and I think our first question is just how you came to decide to write about this for the book. There's so many different components of this bigger social justice issue.
Myself and Sasha eat and breathe gender, especially in the context of children. So it would be naturally where we would go towards. And we're incredibly interested in the psychological process that can help, children and adolescents around their gender identity and how best to support them within the counselling context. As well as that, we've noticed, if I'm right, Sasha, a huge kind of input of social justice has arrived into our clinical work that mightn't have been as present before. Gender identity was always, gender identity, but it's become a very politicized gender identity. There's an overlap and an enmeshment going on. So it felt very natural.
Yeah, I think this is the primary work that I do anyway. So since 2016, this has been my exclusive focus in my practice. So I've been studying this and experientially kind of learning about this through my practice. So this is obviously the natural subject we would have been drawn to. And I think furthermore, something that I think is commonly misunderstood about the transitioning of children and this kind of new affirmative approach to treating gender identity is that it's somehow been born from very, very rigorous theoretical frameworks, lots of data, lots of information in the medical field and the mental health field. And I think these chapters for us were a way to kind of draw upon like the history of these theories, the history of this affirmation approach, and where it comes from. And in fact, it is not really supported by any evidence. So I think for me, it was really appealing to try and describe to other clinicians or even the general population, why do we have this theory now of affirming children's gender identity and medicalizing it? Where did that come from? Where did this start? And as people will see in the chapter, this isn't the first time in the field of psychology that we have this kind of novel theory that seems very interesting and exotic. And when we run with it to its furthest conclusions, we end up in the medical system as well. So this isn't the first time that this has happened. And I think our chapters kind of highlight the way that this is similar to other things that have happened in psychology.
Right.
Stella, anything else to add there? Does that seem about right?
That was very comprehensive. And our podcast that you mentioned, is almost, well, not exclusively focused, but it is called Gender A Wider Lens, and it brings a huge amount of emphasis on this phenomenon.
You mentioned the history, and that is quite a fascinating point that you made. I've also noticed that when it comes to the current trend in affirmative care, This is ideology inspiring theory, inspiring practice. Whereas historically, it used to be discovery, inspiring theory, inspiring practice, and then going back, tweaking on theory, inspiring practice. My understanding of matters, especially psychological matters, has always been that we test theory based on what we've seen in our practices. This is different. Maybe you can give us a bit of a run through around the history that you wrote about in chapter 6.
The gender identity theory, I think we start out in one of our chapters just kind of laying the groundwork that throughout history and throughout different cultures, there have always been theories about what makes somebody a man versus a woman. I mean, these are in some ways philosophical concepts. In some ways, they've been woven into religious concepts, spiritual concepts. So there's nothing unusual about the fact that human beings have a lot of questions and are trying to understand what makes a man, what makes a woman, what is femininity and masculinity? Do we embody both of these things, or are they completely exclusive to masculinity in males, femininity in females? And we think that the exploration of these concepts is a very kind of normal part of our development as humans, right? But we start to outline some of the theories that really spurred on what we now see as this affirmation model for gender identity. And that started with, there are kind of 4 main figures that we focus on: Robert Stoller, John Money, Harry Benjamin, and Hirschfeld. And these are 4 different people, or 4 different professionals who are endocrinologists, physicians, clinicians, psychologists. And they had these kind of slightly novel theories of like what they were seeing. Clinicians who were working with intersex individuals, they had to come up with a theory to explain why is it that this person with, both sets of like sexual reproductive organs that are somewhat ambiguous, like what makes their personality? Who is this person? Why do they behave the way they do? So in some ways, they were observing, phenomena happening in the clinical context, and then kind of in a post hoc manner, coming up with theories to explain that, like, this person has this different soul on the inside, to explain what's happening with their genitals. So I think if we were to be very generous, these were probably pioneering individuals who were trying to understand their patient population, but then they took the theories of identity that they were kind of conjuring up to apply to the intersex patients, and then trying to kind of impose those onto everybody, right?
Yeah, that's John Money and Robert Stoller. So they kind of in the 1950s and the 60s, they created, like Sasha said, they conjured up, well, maybe we all have a gender identity, because these intersex individuals, it's more difficult to ascertain whether they're male or female. So maybe we need to kind of find a theoretical perspective that will explain whether they should be female or male. Now, science has advanced, and now we can actually scientifically categorize somebody as male or female. Now, it mightn't be immediately, it's a very small group of people, but it can be a little bit more difficult, but every person is male or female. And they didn't as such know that. We weren't as advanced scientifically. And so they decided, well, there's male and there's female and there's intersex, and each person might, being the point, have a gender identity. And if each person does have a gender identity, then if you're growing up in the wrong gender identity, you will feel askew, you will feel wrong. And that person might need to be helped to transition. Now, I'm kind of adding the second point onto it, if you follow me, but that's how people have ran with a ball about this concept of gender identity, which is very like, I'm brought up a Catholic, and my mother would consider me to have a Christian soul. And I'm like, that's very nice of you, mother, but I don't think I have a Christian soul. And we jog along. She believes I do. I believe I don't. And off we go. It's the very same with gender identity. Some people say, oh, yeah, I have a gender identity. It's feminine or it's masculine. Some people say, no, I was born as my body. I didn't get any option. And I've been influenced by my bodily functions, by my hormones, by my experiences, my socialization, and that this is who I am. There's no inner psyche that's pink or blue or any other color within me. So that's gender identity theory that has been kind of, it was an interesting theory in the 1950s and 60s. It didn't grow legs until really quite recently. And now it's been presumed as fact in a huge amount of contexts. There are other theories. We could beat you over the head with lots of other theories. Like Sasha said, you know, Hirschfeld, he had this idea. Now we're talking about the turn of the, 20th century, 1900s, 1920s. He talked about a third sex. There's a consistent kind of theory throughout history where men, frankly, are a bit uncomfortable around certain types of men and try to kind of bat them over to the women.
Right.
Do you know what I mean? Rather than expanding our understanding of men. That is a kind of a notable, these are interesting theories. Queer theory is interesting.
Can I ask a question, Joe, about the McKinsey scale of sexuality, right? You're familiar with it, that 0 to
It's
whatever it is.
McKinsey
1 to
scale.
6, yeah. McKinsey scale.
Okay, so my question, and this is because I haven't heard very many people bring this up at all, and I wanted to ask how that plays or could play a role, because that idea started us thinking about sexual preference or sexual orientation being fluid, right? How does that connect to all of this?
I'd be interested to know if Sasha knows much about it. I do know that it was certainly the heyday, that kind of 1950s, 1960s for a lot of that. And there was conversations between, let's say, John Money was big into gender identity theory and Kinsey and stuff. I don't know. I think you're making a good point. What is the overlap and stuff like that? I think it was a time for a lot of exploration around our sexual self and our identities. And, often in these times of exploration, some brilliant points can come out and some dreadful points can come out. And our job in civilization is to, take the good and leave behind the bad. That's my own feel of what happened then.
Yeah, I mean, I haven't studied the Kinsey scale in great detail, but if I'm remembering correctly from, undergrad, the Kinsey scale kind of demonstrated that there's actually a spectrum of sexual orientation.
Yes.
Whereas typically in society, especially at the time, we really had like 2 categories. You were gay or straight. And then, of course, there were people who were bisexual, but frankly, that's not always given much attention. But what Kinsey discovered is that people can almost kind of slot into like percentages, like a pie chart. Like you can be 99% straight, but then have 1 or 2 experiences in your life that indicate some type of same-sex attraction. And of course, as all spectrums go, there's a huge kind of variation in between. And I think what comes to mind for me when I think about that is, if we look at the queer theory concepts, which are that heteronormativity is imposed on us by a society that prefers heterosexuality, right? And then you look at something like the Kinsey scale, which I don't know for sure, but I imagine is a pretty valid scale. I know that Dr. Lisa Diamond is also a sexuality researcher, and she found a really similar trend that actually people have far more homosexual attractions and or experiences than they typically might be obvious with their, straight relationships. So if we believe that we've had heterosexuality imposed on us, forcefully, and we look at this research about sexuality, we might think, well, the way to liberate oneself is to actually disidentify with heterosexuality and let people be as gay as they want to be, per se, right? And I think that same concept is being used to apply to gender identity in a way of saying, like, yes, there's all these teenage girls suddenly announcing that they're transgender, but because we live in a cis-normative society, that cis heteronormativity had been imposed on them, and now they're actually just being their authentic selves, their trans authentic selves. So I do think that laid the groundwork, I guess, for the pushback against somebody like myself or Stella, who are really saying, no, we don't actually believe that affirming these identities is best for these young people. Others might say, yeah, but them being cis their whole lives was because they were in a box and now they're freeing themselves, so to speak.
Can you just quickly share what cis means, and then we'll go to Jaco?
Sure.
We, of course, in our community know, but we're trying to help educate others who maybe don't.
Well, the term cis, my understanding is it comes from organic chemistry when you have 2 parts of a molecule on the same side, and trans is when one part of the molecule is on the opposite side. So cis and trans, I think in Latin just means the same or different. So a cis person is supposedly a person who, I'm going to use lots of quotes, but identifies with the gender associated with their birth sex. So I am female. I associate with being a woman. Woman is typically associated with female. So I'm cis. If I identified as a male or as non-binary or some agender or an infinite number of other genders, I might be trans because my identity does not match up with the gender typically associated with the birth sex. Now, I say that with quotes because I'm not sure I buy into that theory.
Sure.
That's how it's typically used.
Great. Thank you.
I think that's a great explanation and good memory there, remembering organic chemistry.
This is a world that's filled with jargon, and in a way it's an obstacle for people to understand what's exactly going on, and it feels a bit off-putting for people. It reminds me, I'm from Ireland, it reminds me of Northern Ireland politics, that it ended up with very few people actually knew what was going on in the North. There was an awful lot of jargon, there was an awful lot of very intricate points, and it was becoming more and more kind of, these very few people know about it, and everybody else is just saying, I don't dare talk about it. It's a minefield. And that is very unfortunate, I think, for everybody.
I think it is also important to, and that is something that you both mentioned, that these theories, at least initially, developed within a specific context. They had not had a development or an understanding of genetics yet. They had to come up with these kind of metaphysical explanations of gender and, you know, having a gendered soul or something like that. And it's interesting that because of their lack of knowledge, which was time appropriate, that currently that is actually being exploited to further this idea of gender as having this mystical identity, and according to which you need to then change your behavior or change your biology.
Yes, but I also think that these metaphysical theories about gender are an attempt to grapple with something that seems much more esoteric than just knowing someone's genetics, right? So for example, many adults, many of whom are gay, but many of whom are not gay, can give you a very rich history of their childhood of experiencing something that felt incongruent about their gender, right? Like a boy who doesn't fit in with the other boys, who can't play along with the macho games, or a young woman who's gay and has always had very masculine typical preferences and feels weird when she starts being attracted to girls. So having a knowledge of someone's genetic makeup doesn't really kind of dismiss or explain some of those like experiential anomalies. Like I think a lot of people have had that experience. Stella has had a very, very interesting experience with her own sense of gender. So I don't know if that kind of makes sense, but I think that people are reaching for something beyond just like a scientific explanation to say, why are some people experiencing gender in this bizarre way, or in this way, maybe it's not bizarre, but that doesn't fit the typical pathway.
Gotcha.
You could say that about a lot of different, it's almost the crux of why are we all so different as humans? Like, why are some people so organized, and why are some people so chaotic, and why are some people so, I don't know, spontaneous? And you know what I mean? We've never it's not your family background. It's not necessarily a socialization. I've just came across, I was working earlier with clients, and just, you know, that is specific thing, 2 children raised in a similar household, coming out like so different. We really haven't nailed it. So gender is just one of many ways that we haven't figured out why.
And that kind of leads me to this question, actually, that Jaco and I were talking about before you ladies jumped on. But so there's all this desire for questions and to understand and to want to know, and we don't have a lot of answers sometimes, where people are feeling that way. It's interesting though, because what I pulled from one of the chapters was a quote here, which I think is fascinating. Is when patients are vulnerable and clinicians are emphatic zealots, the stage is set for medical scandal. And I think that's so powerful, because to some extent, I'm hearing a little bit about this vulnerability within questioning in itself creates
Mhm.
vulnerability. So if you could speak a little bit to that, I would love to hear what your thoughts are, because it almost feels in a way that what that's saying is that it's exploited.
Yeah, certainly. If you look at other scandals, and in fairness, psychology and psychiatry hasn't covered itself in glory. There have been some scandals, and a zealous practitioner is a key element. So if you look at the repressed memory kind of movement in the 80s and 90s, if you look at the kind of the satanic kind of panic of, you know, in the nurseries in the US, there's been a few different kind of movements almost where zealous clinicians who come upon a theory and are kind of delighted to have the unicorn in their office because it feels very special. It kind of lifts the lid on a murky side of people who work in our professions, which is we like to be saviors, and we have to be very careful around that. And if there's a new working theory around, we can be almost delighted to see that in our office and think, oh, I've done a workshop on this, I've been reading about this, I'm all over this. I think that is something that we as a profession need to look at, because I think it doesn't bring out the best in us. I don't know if that's really what you asked us, but certainly that's what came to mind there. I know you did a great piece, I know, before, Sasha, on the lobotomy scandal, which is kind of very much what Christina's talking about there, I think.
Yeah, and I mean, I think everything you said is right. It's a kind of there can be an excitement. Let's say you are a therapist. Maybe we could talk a little bit about what happened with the repressed memories and multiple personalities.
Oh, yeah.
There was a book called Sybil that was written in the 1970s. And it was co-written by a psychiatrist and like a ghostwriter, or kind of like an assistant, about a case that she had in her practice. And it was a young woman who came in, and this therapist had been nursing this concept for a long time in her mind that people could have multiple personalities living inside of them. So this was kind of like her invention. And she had a woman who came in, and something like one day the young woman started to talk in a voice that sounded a little childish or something like this. So through a very extensive therapeutic process, this therapist and this client came to believe in like this kind of co-evolving way that she had multiple personalities living inside of her. And this therapist, using the help of another author, wrote a book about it. And this book, Sybil, was like a huge hit. It was a bestseller. And you know, we quote in our chapters like a psychiatrist named Francis Allen who was talking about this, and you know, he said that there were thousands of people with this diagnosis within a few years. So young women would read the book. It was a made-for-TV movie. They were on Oprah. They were on talk shows. And this concept of having multiple personalities inside of you had an elaborate theory behind it, and it sounded really compelling. So the concept was, if you were traumatized to such a profound degree that it was overwhelming to your psyche, the psyche could split into multiple people to kind of help absorb the shock almost, so that each person could take a little bit of the trauma. And even as I say it, I find it truly compelling. I mean, we know that human beings do bizarre things in the face of trauma.
Yes.
Right.
But what happened was there were all of these very elaborate kind of training protocols, and therapists went to workshops to learn about this, because of course what happens is, we see now, as Stella mentioned, you see more and more gender dysphoria as a clinician, and you're like, I better learn about this because I'm seeing it in my practice and I need to support these individuals. But if the theories being taught in these psychological trainings are these kind of exotic theories, then you're kind of creating this reinforcing cycle whereby the more training the therapist gets, the more primed they are to be that zealot. And then the more vulnerable the patient is, that the patient is probably earnestly trying to learn about why they're having this experience and reading more about it. And the more they read about it, the worse it gets. And I mean, we see this in our practice, right? Like kids who are trying to learn more about gender dysphoria end up becoming more and more and more gender dysphoric.
Right.
Yes.
And it's not that they're faking it, right? They're genuinely vulnerable. Yeah.
Right.
And could I add, there's something incredibly attractive to all of us to think that there is a reason for our distress. There's one thing that happened. There's one thing, and that's why I feel all of it. Because the human condition, I would argue, is a complicated, messy place.
Absolutely.
Yes.
And worries and, you know, inadequacies. And we love the idea throughout history of thinking, this is what's wrong. This is it. And it's a neatly packaged kind of the problem. And if we know what the problem is, then we can look for this.
Solve it. Yes.
Yeah, it's so attractive to us. It's so
is.
attractive to every human. And each of these kind of scandals had a kind of, now we know what your problem is. Your problem is ABC, you know. And at the moment, you could argue the problem is you were born in the wrong body. You've got the wrong gender identity, and it needs to be fixed. It's an incredibly alluring idea about how to solve the messiness of being human, the worried, messy psyche that many of us have.
I want to add something too, because as you were talking, Stella, I thought about my own experience as a therapist. Sometimes I'll have a session with a young person and they throw me a curveball. They share something that's very painful, or they describe, for example, struggling with something very complicated like self-harm or something that scares me. And what I have often done, especially when I was a newer clinician, is I would quickly start researching. What's the technique for this? How do I help this person? Because you're coming from a place of genuinely wanting to assist your client. And so I think that is what makes the clinicians also quite vulnerable to adopting these theories, because they want to know what do I do when a person says this or this or that? And I think the more, the less exposure you have to that type of problem, the more novel it is, the more likely you are to feel like, I can't trust the kind of foundational staples in psychology. I need a new theory, because like I've never heard somebody tell me they're born in the wrong body. Now that I've heard that, I need a new theory because the old stuff doesn't feel like it applies. So it's just, and I think the point that we are saying in the chapters, we actually do need to rely on the foundational principles of psychology. It's not actually as complicated and esoteric and exotic as we make it seem sometimes.
It's what you're describing reminds me I was a professor, so I had all these graduate students that are starting their traineeships. And then as a clinical supervisor, the anxiety and angst around what do I do, and kind of departing from the foundational principles of being with the person, being in relationship with the person, holding space, you know, all these kinds of things that are therapeutic in and of itself. So what you're talking about is bringing to mind all of the times that, gee, I want to have all these interventions in my head ready to go, pull out in my arsenal here of tools, and that is not what happens in the room. And I used to say to them, hey, most of the therapeutic space and therapy in general is just going to be gray. It's gray. It's uncertain. There's very little black and white, only a couple of things, right? And everything else is just this gray, fluid uncertainty, and living in the uncertainty with your client and not knowing where you're going to end up. And that fear that shows up for them in doing that. So I think that's very natural. I mean, even me as a clinician 18 years later, you know, from the very first time I saw a client, I can relate to that, idea that does play a role. Absolutely. So,
and then they're being flooded with all this information around this new metaphysics of gender, bamboozled by terminology, new language that needs to be learned, new understanding of reality, and you're sitting with vulnerable people. When people are vulnerable, especially during these sensitive stages in our development, people are also prone to or susceptible to suggestion. And this tendency to assign adult categories to children is quite peculiar. That they want to assign something like sexual orientation even to children, or stable gender identity if they're insistent, persistent, and consistent. I don't know for how long. How long should persistence and consistence and insistence be? 6 months?
The diagnosis is 6 months.
typically
Highly
psychosis.
flawed, the
My
DSM in many ways.
goodness.
Absolutely.
My goodness, if I were to be to be classified as a teenager only based on how I felt for 6 months, I would have been a fruitcake, let me tell you. And I think many people
Yes.
would attest to that.
Yeah, it's very interesting. I suppose I was a very intense, I still am a person when I was a kid, very very kind of sure of myself, very kind of, I enjoyed almost intimidating the adults in the room about the certainty of I was a boy or whatever, or how boyish I was or whatever, you know, because I had my own generations as a kid. And I remember adults almost testing me and being kind of me passing and me kind of going, yeah, that's right. You know what I mean? And so a personality like that is a certain type of personality. Now, I've got 2 kids and I could see one of them would be like me, who would have that pushy assertiveness, and the other would be much more gentle, much more mild, wouldn't be. And I think this whole consistent, persistent, insistent, that's a personality type. You know what I
Right.
mean? It could be about ice cream. It could be about gender. It could be about what room they're going to sleep in, where they're going to sit in the car, whether they're going to press the elevator button. You know, this is how they approach life. And there's another type of person who's much more uncertain and mellow and gentle about their opinions on everything.
Yes.
And it's missing that. That doesn't mean the depth of the gender distress.
Precisely.
And in fact, in my clinical experience, it's the shy kid who has a very hard time asserting him or herself that is having this tremendous internal struggle, but they don't want to rock the boat, so they don't say anything. So in fact, their gender distress can be much, much bigger than what you might assume, because they keep it locked up inside and they go with the flow so as to not upset mom with my boyish outfit, for example. So I think this insistent, consistent, persistent thing is a terrible gauge of what a person is struggling with in terms of their gender, their identity, or any other thing. It's like a force of personality, and that shouldn't be. And I mean, it is kind of an example of the squeaky wheel gets the grease. Isn't that how it goes? It's like the most obvious distress gets attention, and then actually what we know is a lot of kids are suffering internally in a very kind of hidden way.
Yes.
And it's creating a society where children learn that the squeaky, you know, so that they learn you need to elaborate, you need to almost be theatrical about your pain, because you will get a lot more attention. That is not good for society. It's not a good cultural expectation on children, and they're learning it.
I actually think this completely has to do with our topic in our chapter, because that's actually the assumption behind affirmative therapy.
Let's talk about that. Let's
go for it.
The assumption is we actually don't know which kids are trans, and rather than assuming that most kids are not, because that would traumatize the trans kids.
Yes.
We are going to operate on the assumption that any kid might be trans, and any challenge to that stated identity is trauma. So like, that's exactly what lands us here. And as you pointed out, Christine, this is happening way beyond just the world of gender identity therapy.
Yes.
This is happening in a lot of contexts.
Yes.
So it really sets us up for a tough spot when the assumption is that the most vulnerable among us need everything to be tailored to them and screw everybody else, basically.
Right.
Yes.
The rest just needs to sacrifice. And it's such an honorable thing to sacrifice, see. Then everybody feels heroic. We saved the world. It is a zeitgeist we find ourselves in.
Yeah.
It just gets punctuated along these critical topics. Right. What do you make of the co-opting of conversion therapy and the sentiment around conversion therapy and the appropriation of that in the treatment of trans adults or even gender dysphoric kids?
I think this is something that really needs to have a lot of attention. You know, conversion therapy back in the day, in the, you know, in previous decades. It was a barbaric practice that was really cruel. Conversion therapy, as it was always known, was this idea. It was a practice, and I wouldn't call it therapeutic on any level, but it was certainly a treatment people used to try to convince people out of their sexual orientation, generally gay, lesbian, bisexual. And so they would go to a practitioner who would try to convince them. They might force them to watch certain types of porn. There was electric shock treatment. There was really barbaric, cruel, awful, you know,
Sniffing
really
ammonia salts.
Yeah, there's so many awful treatments. Really, really horrible.
Including estrogen, might I add.
Very good point, which we will circle back to. Thank you, Sasha. And so that was for gay, lesbian, and bisexual people in previous decades and centuries, really, when it was looked down upon to be gay, lesbian, or bisexual. And it has moved on, really. I know there was a scoping document in Ireland, and they tried to cover the whole of Europe with it, trying to find conversion therapy in the last 20 years. And they couldn't find any. What they did find was a couple of religious zealots who were carrying out, at the same time as they were carrying out exorcism, were also carrying out conversion. Like, we're talking extreme zealots. I don't think that's got anything to do with therapy, and that's religious zealotry. And there might be people who call themselves conversion practitioners.
I think it's reparative therapy is the kind of contemporary term.
Yeah.
Sexual reparative therapy, yes.
And some people who really have maybe strong internalized homophobia, they don't want to be gay, they don't want to be lesbian, they might try and go for this. It's barbaric, it's not appropriate, and I really dislike the word therapy with it, if you follow me. I just think it's not therapy. It's certainly nothing to do with what I would consider therapeutic. And in recent years, there two things have happened. One is conversion therapy has suddenly got an awful lot of attention, even though there has been no uprise in the numbers of practitioners who are carrying this out. So, you know, it's kind of a solution looking for a problem, insofar as there isn't huge numbers of these reparative therapists anywhere. And at the same time, they have stuck on gender identity to this concept of conversion therapy. And it's made a much broader and kind of anti-therapeutic, anti-psychological kind of concept, where suddenly conversion therapy has moved from being a barbaric, awful, terrible practice to being a much more esoteric. If you try to change a person's gender identity or sexual orientation within a therapeutic practice in any way, you might inadvertently carry out conversion therapy. Now, that's a long way from coercive efforts to try and harass
Absolutely.
someone.
Wow.
Oh,
wow.
Absolutely.
That blows my mind.
I think you nailed it. I think you nailed it right there.
Yep.
Yeah.
And isn't it interesting how gender dysphoria is the one condition that's treated as special and different from every other phenomenon, psychological phenomenon we find. In every other psychological phenomenon, we treat symptom as a signifier pointing to something else. It's a highly symbolized signifier, something that needs to be decrypted. We do that with every other condition. But as soon as you do that with like gender dysphoria, then suddenly you're performing conversion therapy. Fascinating.
Well, it is.
I mean, Kenneth Zucker used to do it, and he was successful. I mean, the research he's published, I mean, he was no zealot. He was just a committed psychiatrist. And between, like you said, between 60 and 80-something% of kids, you know, desist, and they live a life congruent with their biological sex. And he was persecuted.
I think one thing that I feel very strongly about is we need to protect the integrity of psychological therapy.
Yes.
Good ethical psychological therapy. And what drives me a little bit crazy, and I do go a little bit crazy about this, is every accredited therapist or licensed social worker or licensed psychologist is already bound by ethical standards of care. So it is well catered for. We don't need this. We have it with our license to work. Because we have standards that we abide by. So you could not be a reparative therapist and also, if you follow me, abide by the standards that you work by. And so this entirely unnecessary conversion therapy bans that are sweeping in around the world are quite a clear attempt to stop psychologically good ethical therapy where people might explore identity in an ethical manner. And why that's happening, you could say, is probably political, but it has really caught on, because I know in Ireland, this extraordinary report came out about 2 weeks ago, and my head nearly fell off, because in the report, they said, they were talking about conversion therapy, which they've already done a study and figured out that it is not happening. And so what they did was an anonymous online survey. And in the anonymous online survey, a 12-year-old, apparently, somebody said that when they were 12 years old, they got electric shock therapy for conversion therapy. And I'm like, that didn't happen in Ireland. In Ireland, we have such a small level of electric shock therapy. It is only for chronic, very treatment resistant, deep kind of mental illness that people are like, it's really, really, really carefully applied and has been for decades. And the idea that this 12-year-old, it is just so outlandish that it's like, that's what you get when you get an anonymous online survey. They
absolutely.
I do want to point out, though, because I think for those of us who are viewing gender dysphoria as a developmental condition for which the medical interventions have serious burdens and we should avoid them, like, we are looking at this saying, how in the world are we conflating these conversion therapy things? But I do want to point out, to your point, Jaco, that homosexuality was in the DSM as a mental health condition. One of those conditions that, like you said, we try to understand where it's coming from. It's an indicator of other problems. And when people view gender identity as a civil rights issue, similarly to how things have changed with homosexuality, this slots in perfectly. So this is a distinction that I think is, I think it's confusing to a lot of people. A lot of well-meaning people ask themselves, well, what if this is the same, right? Because if you look at the kind of narrative on which, like, the affirmative care model has been built, it's kind of piggybacking on the gay rights movement, saying, you know, there's nothing wrong with us. This is perfectly normal variation of human experience. And I think the missing piece, of course, in my mind is that, well, medical interventions are applied here.
Yes.
So if we get it wrong, like, the false positive has a much more serious consequence than, affirming a young person's gay identity and they, sleep with a couple guys and realize that's not me. No harm done.
Yes.
Right.
But when you start messing with someone's body at a young age, the stakes are just infinitely higher.
That is what agitates me more than anything else. I mean, I love my colleagues to death, but the idea that this is a trend or a fad or they'll grow out of it, we're using medical intervention now. If you listen to even a couple of detransitioners talk about what that has done to them, their reproductive organs, not being able to even have an orgasm, not being able, a lot of chronic pain, it's absolutely horrifying to hear about that. So it really gets, I just totally gets on my last nerve when people say, well, Christine, it's just a fad or it's just a phase and it's fine and we're just going to get through it. And meanwhile, they're marching, their children over to the doctor's offices and whatnot to get started on all of that. It leaves such a sick feeling in my stomach. I mean, this is just absolutely
extraordinary when you look at the affirmative model, which myself and Sasha have. It's like, it's very nebulous. It's very hard to say, who devised this and where's it's just it kind of arrived kind of gently about 10, 12 years ago as something that we should all do. It sounds very nice. you know, gender affirmative care. It sounds very positive. Who could be against it? And yet, what it's child-led. It's rather than child-centered. And so, if the child, at no matter what age, declares their gender identity, we affirm it. Now, affirm is a very interesting word. And I would say it should be confirmed that they're using here, because effectively you change their pronouns if they want to change their pronouns, no matter what age. They could be 5 or 4. Change their name, let them go into different toilets, let them go onto different sports teams, different changing facilities, and require participation from everybody else to go with this changes. And it has arrived, like I say, and it has stayed. People presume this is a positive thing, and it has not been tested. It doesn't have a long-term evidence base. It doesn't even have a strong theory behind it. It's just, it sounds good. It's almost the epitome of our cultural sickness at the moment, where a lot of vacuous, shallow, positive, vaguely positive statements are presumed to be good.
Right.
Yeah, I'm not a fan.
And I mean, part of the affirmative protocol, and as Stella mentioned, you're so right to mention, it's quite vague. It's not like there's a very simple, like 10-step checklist that people are using. It's almost like up to interpretation. There's a lot of subjectivity in this entire project, right? There's a lot of subjectivity. But I mean, one of the pieces that has been, I think, the big focus of our work is the early medical intervention using puberty blockers. So, you know, if we believe that we have to affirm and confirm a young person's identity, and they're 6, 7, 8, and they're approaching puberty in the, you know, young adolescent years, if we have the medical intervention to stop the puberty or halt it, and it's often said because that gives the young person time to think, which we know in practice is not true. They go on to medically intervene all the way.
Yep.
But that is it's like the medical availability of puberty blockers creates this other layer of the affirmative model wouldn't exist without puberty blockers, because prior to the use of puberty blockers, everybody, dysphoric kids or not dysphoric kids, were all subject to nature and the power of nature and the power of biology and the power of puberty to move us into that next phase of life, whether we like it or not. But the use of puberty blockers kind of created the possibility of like extending this, the child's desired gender, the fantasy of this gender,
Right.
in a way that frankly is medically incredibly risky. We have no idea what is going to happen with these young people. There are serious complications, medical complications. So the affirmative model, like Stella mentioned, it's like this theoretical concept, but then you add in the availability of certain medications, and all of a sudden you have rubber stamped, medically speaking, an experiment, like a psychosocial experiment.
And can I just add on, because it's such an important point what you make there, Sasha, is we're medicalizing identities. And that is the concept.
Yes.
Once you put a medical kind of intervention onto an identity, you're medicalizing an identity. And effectively, what is an identity? You could say it's our personality. We're medicalizing personalities. We're you know, it's extraordinary when you stand back and think what we're actually doing when we medicalize an identity. What is an identity? What makes an identity? And to medicalize it, how we're creating something that we have never done before. It's extraordinary. It's very much a case of, you know, with science, just because you can, should you, is what's going on here.
Should you?
I mean, and there
have the ability to, we have the technology for it, should it be used?
Yeah, that's what I mean. Yeah.
I mean, that moral question, huge.
Yeah.
Jaco, go ahead. I think you
and the targets are children. I mean, they're ignoring decades of research in a child's development in their identity, and how fluid and malleable and eventually settled that personality becomes. And yet during this flux, this period of change, they ignore all of that. 6 months, insistent, persistent, consistent, you're through.
I know, I was years. And there's a strong cohort, which we mentioned in the chapters in the book. There's a strong cohort who consistently gender nonconforming who are gay, who turn out to be gay, lesbian, or bisexual. And so we are in severe danger of medicalizing these children who will one day grow up to be gay, lesbian, or bisexual. And we're in without a doubt, if you stop their sexual awakening, if you block it with a puberty blocker, their ability to figure out that their gender nonconforming was something to do with a burgeoning sexual orientation that would one day come out when they became sexual beings.
Yes.
You prevent that sexual awakening. How will they ever know that? Because it's been blocked. And then when they're older, a chemical adolescence is then kind of put upon them. And that could be estrogen or testosterone, but it's the opposite. And then they go into a chemically induced adolescence of the opposite. Wow.
Unbelievable.
It's extraordinary when you get into the mechanics of what we're actually doing here.
Yeah, it's Frankensteinian. It's scary. So, like so many psychogenic epidemics, what would you recommend should be the approach with this psychogenic epidemic, this rapid onset gender dysphoria? Okay, so I might be asking you a complex question here. I might be asking you 3 questions in one. I'm thinking Dutch protocol, which is usually evoked. I'm thinking rapid onset gender dysphoria, which does not necessarily follow the profile of the people tested in the Dutch protocol. And I'm thinking psychogenic epidemics and the resolution of those.
Since we've written the chapter, a lot has actually unfolded regarding the Dutch protocol. So
okay.
You know, at the time that we wrote the chapter,
tell us what the Dutch protocol is, just for the listeners.
Sure.
And
we'll preface it with, this is a very fast-moving landscape. We're telling you something that is like bang, 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 and it's dense. There's a lot of information. Go.
Okay, so in the early 2000s, it's so much. I mean, we could be here for hours talking about
I know.
We love
in the early.
That's why they always go too long. So, same with that.
The Dutch, culturally speaking, often being pioneers of very progressive kind of compassionate interventions, which are often new, often a bit edgy for the rest of the world. They often find themselves kind of trying out something for the first time, okay? And the Dutch in the early 2000s thought that it would be helpful if they could take dysphoric children who have had a history of childhood gender issues and whose difficulties are ramping up with the onset of puberty and slow down the puberty or stop the puberty. So they started to use puberty blocking drugs, which had historically been used for precocious puberty in a small number of kids who start puberty very, very early at like 4 or 5, something like that, or used as kind of chemical castration for sex offenders in order to reduce their kind of rate of criminality. They thought they would use these drugs to slow down the puberty of dysphoric kids. And they started a study with 70 participants, and it whittled down to only 55 participants because 15 dropped out. And what they did is they kind of had 3 phases. The first phase, they blocked their puberty. The second phase, they introduced cross-sex hormones at the age of 16. And then in the third phase, there was surgical intervention. So for the girls, it was mastectomy, and for the males, it was vaginoplasty, the production of a pseudo-vagina. And in the course of this study, 1 male participant died. The children were shown to have very, very slight improvement of overall function, but not even clinically significant. And the way they measured the reduction in gender dysphoria is something that we expand on in detail in our podcast, was by giving girls who wanted to be boys a girls scale to assess gender dysphoria at the beginning. Then after intervention, they gave her the boy scale, which asked things like, do you like being seen as a boy? Are you enjoying being a boy? And of course, she rated them very highly. So it's arguable that they actually proved that the intervention itself created the reduction in gender dysphoria. It could be said that giving her the boy scale in and of itself would have produced a very low rate of gender dysphoria because she wanted to be a boy from the beginning.
Right.
So this protocol, which, you know, anyone who has evaluated this evidence finds it to be of very low quality. And I don't just mean lay people like myself. I mean, when there are systematic reviews and kind of evidence-based assessments, this is considered very low quality evidence. But this Dutch protocol has been hailed as like the gold standard for treatment. And not only was it poor quality evidence to begin with, but the types of young people in that study were dramatically different from the thousands and thousands of kids who are kind of rushing the doors of gender clinics today. They're not the same sex, they're not the same age, and their onset of dysphoria is not the same.
Right.
So we have problems all around.
Absolutely.
Absolutely. So I think that's been something, as we have studied more and more and more, we have also become aware of the problems even within the supposedly judicious use of the Dutch protocol. Even then, we found it to be seriously troubled.
Right. Internally flawed.
When you kind of highlight, like, okay, a study of 70 kids dropped down to 55 and one of them died as a direct result of the interventions that were used in the trial, it kind of stops everything, because arguably that was the end of that trial and you pack up and go home. If this was a trial for a new type of Coca-Cola or a new vaccine, 55 kids and one kid dies, good luck, goodbye, you're over.
Yes.
And so for it to be termed a gold standard was extraordinary in the first place. Way too few kids. This whole switch of the scale. So if you'd asked a girl who's 12 whether she liked being a girl, liked being perceived as a girl, and if you'd given her no interventions at all and 5 minutes later gave her a different scale which said, do you like being perceived as a boy? And how do you like looking as a boy? Immediately those answers would have been dramatically different. So just because they intervened with all these medical interventions and then gave the different scale, it was a shoddy protocol in the first place, and it got hailed as a gold standard. And then people, as Sasha said, sorry, I'm repeating everything you said, Sasha, but I'm just emphasizing
Go for it.
So extraordinary that this became a gold standard.
Right. It reminds me of that cognitive bias, post-purchase rationalization, where you're committed to something. You're the possibility that this might have been too big of a commitment, but you need to make it work now. So you rationalize yourself into feeling satisfied with what you did. That's pretty much, that follows the process pretty much closely. After surgical intervention, then to give her this assessment, my goodness, poor child. If I were her, I would try to rationalize my commitment, the irreversible change that has just been imposed upon my body. I would have done that too, right?
And you raise a good point, because what we're starting to see as some young people are detransitioning in their early 20s is, you and Stella's really experienced in this too, so feel free to add to this. But what I hear in their stories is like they're trans-identified, they've had these medical interventions, and it might start with a small little thing, like just kind of questioning the theory behind it, or noticing that the medical care they got was less than optimal. And this little kind of seed of doubt will start in their minds. And what I've noticed is, from watching these young people's process, it's pretty incredible. Oftentimes they're hanging on to their trans identity, doing exactly what you said, Jaco, of like rationalizing. Well, it was a bad process, but it worked for me. Or it wasn't right what the doctors did, but I'm still benefiting. And then usually there's like a moment where the fantasy breaks.
Right.
It's a heartbreaking moment. And then they go, oh my God, what the F has happened to me?
Right.
What have I done? And then it's almost like that kind of buyer's remorse sets in, to use like
that's the other thing.
Behavioral science things, right? And then all of a sudden, all the justifications crumble, and you see these young people go into a deep despair. They lose their sense of trust for everything. They lose their trust in themselves. How could I be so foolish to do this? I mean, it's just a devastating process. And I think you see a lot of clinicians, like the Dutch are a great example. We've been talking about the Dutch, we interviewed the Dutch, and they're just grasping so desperately to this idea that this is helping people, even after we're starting to see maybe for every 10 people you helped, someone's incredibly harmed. So at what point do you start to just say, let's slow down? And I think this kind of sunk cost, imagine parents who have started this transition process when their child is very, very young. How can they even grapple with the possibility that this is a bad move?
And that they were instrumental in
Yes.
letting this happen. No wonder people are digging in their heels. No wonder they prefer to remain blind. I mean, the guilt from waking up. Oh my goodness. It is just digging in the heels would be an understandable defense, isn't it?
Exactly.
I know, I remember one detransitioner describing how she would wake up in the middle of the night. All during the day, she was, fine with her trans identity. And then in the middle of the night, she would wake up going, oh my God. It was like her subconscious would kind of come at her at night. And then the next morning, she kind of almost back into pro-trans. Then the next night it would come at her. And, there was all sorts of sleeping problems. And I could so imagine how you just bat it away.
Absolutely.
I think regret is a very interesting psychological concept that we don't really understand, because we fully regret very few things. We tend to assimilate our decisions and say it made me the person I am. It was necessary to go through that. We very seldom say, I regret those 3 years.
Yeah.
We don't do it.
Such an excellent point, which I would love to expand on another episode that we do, because I think that's just that's brilliant. I mean, I'm thinking even about personally how I apply that to my own life as a coping mechanism, right? To be able to move through.
The survival,
permanent changes, right? Survival. It's whatever happened, that's over and done, can't reverse it. And now we're talking here about the same thing that are permanent changes essentially in the body. You cannot revert. I mean, you can detransition to an extent, but I do not think you can fully ever go back, right? So that's just such a fascinating concept to me of how we assimilate in order to be able to cope with the choice. The devastation of the regret is it's too overwhelming to tolerate. Psychologically, emotionally.
I just want to say, not everyone feels this regret, of course.
Of course.
I mean, there are some people who had a very concrete problem as far as they understood it, and the dysphoria was really palpable, and transition solved this concrete problem.
Sure.
And I think what we're saying is every solution to a problem always comes with a set of trade-offs. And I think the chapters were a way to say, everybody is in this kind of mass delusion where we pretend like reality is not real, but these gender identities rue the day. And we're saying, if people are going to opt to give their children, or if a young person is going to opt to take these interventions, we need to actually be aware of what the trade-offs are, what the psychological drivers were that perhaps led you to this conclusion.
Yes.
And what happens in the long run? Because if we just go based on affirming identities, then none of that actually gets to be formulated into our decision-making process.
Excellent point, which is a perfect way to start to draw to a close the last couple of questions we had. I think you just answered one of them, Sasha, which was about what you want people to take from this. There's a couple of points of what people can take from what you two wrote. Jaco, if you want to jump in and add to that question.
Yeah, I just have one last question. What is the way out of a psychogenic epidemic? We're talking about critical social justice and its effects on therapy. And we know one of the tenets of critical social justice would be to become an ally, to keep quiet, do not maintain the status quo. Otherwise, you'll be contributing to an oppressive system. Whereas the solution to psychogenic epidemics would be something completely opposite to that. And that would be something akin to keep talking. Not so, Stella?
Yeah, very much so. Usually with psychogenic epidemics, they have an arc, if you follow me, and then people start talking and speaking up and discussing that it didn't really work for them. As far in my experience of studying it, it has been pretty torturous coming out of it. It doesn't, it's not an easy process, and it feels like it's going to be very difficult to come out of this particular one. And I know myself and Sasha in our podcast, Gender a Wider Lens, we discuss it with I think it was Wesley Yang, and he discusses, and Lior Sapir, and they discuss how it's embedded in the schools and the hospitals, and it's embedded in so many places that, you know, they were experts on discussing societal kind of impact. And it was actually pretty chilling to realize this seems to have gone deeper in many places than. So I know that's quite bleak what I'm saying, but it does feel like, as with everything in society, if we can just keep speaking the truth, you know, with integrity and with information, and if we know our stuff, we will get there. But I think it's going to be a long time coming out of this.
Yeah. I agree, and I suspect and fear that there won't be an incredibly satisfying lysis to this story, right? I think based on what I know about the opioid epidemic and epidemics that also had a medical component, it seems like people just kind of slowly back out of it and go, oh, we didn't know how bad this was. And we're seeing, for example, there's the first American whistleblower, Jamie Reed, who spoke about her experience in a gender clinic here in the US. We know,
Such
of
a
course,
courageous woman.
Incredible story. We also know that in the UK, the Tavistock, which is the largest gender service in the world, has been reviewed several times by third parties and has been slated to shut down altogether. So I think we're seeing the beginnings of what might be the end. But I suspect that people will not necessarily be held to account for what has happened. And I think a lot of individuals who look back and realize, oh no, I've done something terrible to many young people, will have a wake-up call for themselves and then become whistleblowers, and we'll see this kind of gently backing out. But as Stella said, speaking the truth and being honest about the impact is the most important ingredient, I think, to finding some sort of way out of this. But I don't think it will be a satisfying reckoning that a lot of detransitioners wish it was. I think it will just be a really kind of oops, and moving away from it. And maybe some shock reporting, the media loves a shock story, but I think there will be a lot of harm left in the wake of this without a lot of satisfying outcomes.
I agree.
And people will forget.
I agree.
And move on to the next one.
Yes.
Yeah. And they'll say, how could this have happened? Mistakes were made. We must learn.
Yeah.
But we can do what we can do, and to be courageous and to speak the truth and to do it with integrity and empathy.
Yes.
That is the way forward.
Yeah.
Thank you so much.
Thank you.
It was such a lovely discussion. Thank you for your courage too.
Thank you. Absolutely. Such a pleasure to be with both of you. And such a pleasure. And we would definitely, and we had said this to several authors, would love to have you come back to expand on a particular topic that may have nothing to do necessarily with the book, but just things that are relevant and topical that we would love to have you on to kind of, dissect and look at a little bit.
Yeah. I really appreciate you having us on and giving us a chance to kind of talk about this topic. It's been nice.